Good evening, everyone present here. I am Faraz from IGCP Med Talks. Welcome all the clinician and healthcare professional on joining us today's very important topic panel discussion. And before starting, as we know that this topic is very much important, let me tell you the topic of today's discussion. That our today's session is a subject of immense clinical and social importance, that is preventing child defects. What each specialty can do. Child defects remain a leading cause of infant mortality and long-term disability, yet many are preventable through timely interventions and coordinated care. This panel discussion aims to highlight how different medical specialties from OBGY, pediatric, and genetic can better collaborate to optimize preconception and prenatal outcomes. And we are joined by our expert panels to strategize this session. So without any further delay, I would like to invite the host and moderator for this webinar. She don't need any introduction. She is none other than Dr. IB Vijay Lakshmi ma'am. Hi ma'am, welcome to this amazing
Namaskar.
interesting topic. Yes, ma'am.
Namaskar.
And yeah, ma'am. Let me tell you the brief introduction about ma'am. Ma'am is a Professor Dr. IB Vijay Lakshmi ma'am, and she is Professor Emeritus, former HOD of Pediatric Cardiology at Sri Jayadeva Institute of Cardiovascular Science and Research, India, and past President of Indian Academy of Echocardiography. So, without any further delay, I would like to hand over ma'am to invite our rest panelist by their introduction, ma'am. Over to you, ma'am. Stage is yours.
Yeah, thank you. Good evening, everybody. Next slide, please. Can you show the next slide? Okay. Today, we are all here to discuss a very, very important point. See, every child that is born, it is a treasure to the whole family. Not only that, to the whole nation. And if it is born with a defect, it is a burden and a sorrow for the parents and also to the country. And hence, we are here to discuss about how to prevent. So, our first panelist is Dr. Parimala Devi. She is a renowned obstetrician, gynecologist, and a preventive oncologist in working in Fortis Hospital. And what is more is she has got a Guinness World Record in what you say the cervical cancer scanning. And apart from that, she is a robotic surgeon too. So welcome, Parimala Devi.
Namaste, madam. Respectful pranams to you. Opportunity
Thank you.
to be with you.
Thank you. Next slide, please. Now we have Dr. Pradeep Srinivasan. He's a director, and more than that, in the Delta Diagnostics, he's the ex-director of radiology in the Fortis Hospital, and he's a specialist in genetics. So, welcome, sir.
Hello, ma'am. Hello, all panelists. Good evening.
Thank you. Next slide. We also welcome the next person is a very renowned neurosurgeon, Dr. Shiv Shankar. He is a medical director and a neurosurgeon of Siddhagiri Hospital and Research Center at Kolhapur, and executive member of the Midwest chapter of neurological surgeons. And he has made a record by doing the neurosurgeries at the cost effective or almost free of cost, and that is something remarkable in the country. Welcome, Dr. Shiv Shankar.
Namaste.
Next slide. We have none other than bright and the upcoming Dr. Srinivas L. He's a consultant interventional pediatric cardiologist from KIMS Hospital, Thane. And he is amazing both in intervention as well as echocardiography. And his work is appreciated among the pediatric cardiologists all over the country. Welcome, Dr. Srinivasan.
Thank you, madam. Namaste.
Okay. Our next panelist is Dr. Priya. Priya Ranganath is a consultant medical genetist and Apollo Genomics Institute of Apollo Hospital and Enterprises Limited in Bangalore. And Priya is a sought after person. Whenever there is any defect or any problem, we ask for the genetic counseling and we ask either Priya or this one. So, welcome, Priya.
Thank you, ma'am. It's a privilege to be amongst this august audience. It's my pleasure to be
Thank you.
here.
Last but not the least, we have with us Dr. Mamata, and she is, next slide, please. Mamata Shekhar is an advisor of genomics and health informatics from USA, and she's the one who's literally working on the genes and then the gene therapy. So she is going to talk about the future toward the end of it. So let us start with the beginning. uh, can we have our slides, please? So, welcome each one of you and welcome all the delegates who have joined us and who are going to see us later on. Yeah, please. My slides. Can I have my slides, please? So until the
Just a second,
slides
ma'am.
are
It's
coming
loading,
in,
ma'am.
yeah, until the slides come, it is such a burden. And being a pediatric cardiologist myself, I know whenever a child is born with the defect, it is always, so much of misery and so much of a problem for the parents as well as everyone. And what is more important is today we would like to have a normal baby. Whether it is a male or female is not important. A normal baby is very important, both mentally, physically. And that is the reason, we are having this whole January as a preventive year, month. And this is going to continue throughout the year. Can I have the slides, please? Ankana?
Yes, ma'am. It is loading, ma'am. Just a minute, ma'am. It's loading.
Keep everybody's slides loaded, so that there is no problem.
Yes, ma'am. Yes, ma'am.
Okay. And what I teach the students is just because you detect one defect, don't be happy about it. Try to look for the other defects in the body elsewhere in the child, because the skeletal defects are seen and then we look into the heart. And apart from that, this is very important because today preventing birth defects, what each specialty can do better, that's what we are going to discuss. Next slide. And all the specialists are going to talk about their journey. So this year theme is, the year, every journey matters. That means every parent, every child, it matters. How it is affected, we are not bothered, but what we are bothered is how it can be prevented. So we joined the National Birth and Defect Prevention Network to bring awareness about the birth defects among the practitioners as well as the patients. So whatever we are going to discuss, this applies not only to the doctors, even for the parents. So let's help improve the health people living with these conditions, and how they are treated and how they are prevented. So for that, we have to promote the healthy pregnancies and then highlight the ways to reduce the risk of birth defects. And apart from that, what treatment is available and what can be done, and how to advocate the health of children and the families living with the birth defects across their throughout their lifespan. Next slide. So in this journey, I would like to show 3,000 years back, ectopia pregnancy was detected. But now we have the echocardiography, the fetal echocardiography, there itself it can be detected. And whenever any defect occurred, people used to think that their parents are sinners or the baby is the sinner. No, it is not that at all. It has got nothing to do with that. Now fetal echo can, next slide, can find out what is the defect and what we can do. Friends, I would like to quote this. Formerly, when the religion was strong, the science was weak. Men mistook magic for medicine. But now, when the science is strong and the religion is weak, then the men mistake the medicine for magic. So, whatever treatment we have, next slide, whatever treatment we have, this appears like a magic, and we can detect and give the treatment also. But what is more important is there are modifiable and not modifiable risk factors, especially the genetics. All the times we thought it is not modifiable, but today it is, and Mamata is going to talk about that. And then the radiation and the drug ingestion during the pregnancy causing the heart disease, and that, we have to bring awareness among the public so that, they are not exposed when they are pregnant. And especially infection and the rheumatic heart disease patients, anticoagulants, and the lifestyle management, all this Dr. Srinivas is going to explain to us. Next slide. And here you can see that what is most important is, okay, what is most important is the environmental factor. In the environmental factor, we have the maternal and we have the other factors. And most important, I would like to stress upon this point is alcohol abuse among the youngsters is a major cause for the fetal alcoholic syndrome in almost 50% of them. And they are becoming criminals also. And apart from that, they are born with the ventricular septal defect, atrial septal defect, tetralogy of Fallot, and coarctation of aorta. And apart from that, the sex hormones and the other drugs that the youngsters are taking, the amphetamine and all those things can also cause the complex congenital heart disease and maternal diseases like diabetes, and that also can cause problems. So here, all these things will be explained to you by Dr. Srinivas. Next slide. So here I would like to welcome with this opening that in the Dwapar Yuga, when Krishna was explaining about entering the Chakra Vyuha, Abhimanyu in the mother's womb kept on saying yes, 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 but then he never heard how to come out of it. But today, what we are going to discuss is not only entering the Chakravyuha and how to bring the baby out of the Chakravyuha. That is the, if it is a genetic problem and if the parents are defective, and then how the folic acid is going to improve the prevent the congenital heart disease as well as the nuclear problem. So let us start with Dr. Parimala Devi. Next slide. So I would like to ask question to Dr. Parimala Devi. Whenever we get the genetic problem like this, we do the karyotyping, and then we tell the parents whether to terminate the pregnancy or not. But now I would like to ask you the question. Can you show the question to everyone? Please, Parimala Devi's question.
It's something antenatally, how do we screen is the first question.
So
Shall
first
I
thing,
go
if
without?
the parent have the husband and wife, they come, they want to conceive the,
Yes.
and then they come. What Garbha Samskara or what exactly you would like to advise them
Yes.
and counsel them before they become pregnant?
Yeah. In the outset, I thank you, madam, and I'm really very much excited in this galaxy of experts, starting from our national expert and global expert, Dr. Pradeep Srinivas, and all others. Especially, it is our basically when a couple comes or a patient comes with her mother for having some preconceptional counseling, which is very important. Sometimes they may just come also, they may not be knowing when they are just married, they want to conceive depending on their age, whether they are getting late for the pregnancy. So many ways like the couples usually present to us, especially whenever whatever it is when we counsel them, the preconceptional counseling especially we have to highlight. And if at all they are in the age group of something higher age group, whatever it is, we have to explain to them what problems may come and what they are supposed to do, especially regarding their weight. We have to tell if there are any already metabolic diseases they are suffering, like diabetes, hypertension, anything, we have to bring to the notice, and we have to understand what they are taking, whether properly they are taking. Especially some people may have some recurrent pregnancy losses also, they may come. That time they might not have done any of the tests till then. They may think that as if it is something can happen to anybody. We have to take all that history. Is there any report from them, from where, whether they lost the baby, any material was sent for the pathology report or autopsy? All these things are very important. Especially optimizing the preconceptional health care is one of our
Yes.
motto actually. And we
Yes,
have
yes.
to also know whether the rubella all these vaccine, if at all they are staying actually in the other country and again they have come to this one, we have to know which places they may have this one. Routinely, we usually do all these starch infections and also rubella,
Yeah.
everything. And also we have to advise mainly, as you said, madam, rightly, the folic acid. Most of the people will not know, even though there is a legal this one, like we have to start folic acid. It is still not very much in the understanding of many of the couples. We have to
And
start the
how
folic
this
acid at
folic
least in
acid
year.
actually helps? Once we start the folic acid, how exactly does it help? And what are the
Yes.
defects that are
Usually,
prevented by folic
because
acid?
of these, the neural tubal defects are very high in our country. Nearly about 20 to 22%. There are neural tubal defects which are actually reported. So, by developing one higher concentration of this folic acid has been found to reduce most of these neural tubal defects. Especially, we have to make it start at least 1 year prior to their plan of pregnancy, but that may not happen in our scenario. Usually,
Okay.
they will not even take when we start also in the pregnancy. So, but we have to make them aware that 400 microgram of this folic acid should be started in a year or before when they plan for the pregnancy, when they get
Pregnancy,
married.
yes.
And after that, it is 5 mg. It have to be continued throughout the till at least the first 3 months when the neural this one and the organogenesis takes place. So
Okay.
pre-conception counseling regarding the metabolic diseases, and also as you were telling in your slide, the teratogenic drugs. Some people may be taking some recreational drugs, alcohol, smoking. Smoking also has been reported. All these things and the proper weight of the body, if at all they are obesity or anything, their effects on the body, all this preconceptional counseling, we will have to bring to their notice and we have to observe them. And
Yeah.
some tests, whatever are required biochemical, usually we ask them to do it and come. And later on, we will proceed depending on the reports and their examination. In the brief,
Yeah,
I am telling.
suppose they have gestational diabetes or hypertension or the hypothyroidism, and with difficulty the lady has conceived. How controlling all this will improve the and prevent the congenital defects?
Definitely, because diabetes also, because of that, we there are a lot of, especially if their hemoglobin C, if they start the pregnancy with high HbA1c, definitely the congenital anomalies are reported to be high. We have to bring the diabetic, the glycemic control first, and then asking her to conceive. But if she has already come with pregnancy, then the management goes with again screening with the fetal genetic specialist and counseling, and what is the incidence, what is her age, and what is her background, any consanguinity. All these things will count for diabetes.
Yes.
And thyroid, as such, usually, unless there are thyroid antibodies, we were not much affected. But especially in diabetic pregnancy and epileptic drugs, if at all she is taking, in these metabolic disorders, we have to be very careful, I would say.
Yeah, very. Thank
Yes.
you very much. How do you decide? Every patient coming to you with pregnancy, you advise or do the investigations, or what are the warning signs?
Usually we consider their previous history, especially the pre-genetic counseling or whatever the genetics test required. We will not apply uniformly to everybody, depending on the risk factors, as I said, like recurrent pregnancy losses, if there is any NTD or anything already reported, some cardiac anomalies the first baby is having, or in the family there are some anomalies which are noted, especially mental retardation. Wherever there is a history and there is some high risk, and the age factor also. And these days we have a lot of IVF conceptions
I
going on.
know
So
the
in IVF,
elderly people,
yes,
yeah, they go for IVF and then
so
yeah.
in IVF also, not uniformly, but most of the time we may have to do the pre-genetic implantation studies, everything, and then proceed. So a lot of
Okay.
these disciplines of fetal genetics and the genetic specialist, all people we have to take as a team and go ahead with these pregnancies, most of the
Yeah.
pregnancies.
Yeah. Next slide, please. Thank you very much, Dr. Parimala Devi.
Thank you so
It
much.
is so important before they plan pregnancy. From then itself, they have to start
Yes.
planning not to have any child with a defect. So now we move on to Dr. Pradeep Srinivasan. Doctor, as per the fetal medicine specialist, what can you do to increase the detection of these anomalies in time? So please unmute, sir.
Yeah.
Sir, we are
Am I?
not able to hear. Yes,
Uh,
now you can go ahead, sir.
Good evening, everybody. Extremely relevant question in the era when ultrasound is being done by a lot of people without standardization. One important point to be noted is in our country, guidelines are not followed, and each person does imaging like how he has been trained, and there is no uniformity at all. Only last year, the IRIA has brought out Indian guidelines for imaging. So imagine
Okay.
in the last 25 years or so of ultrasound imaging in our country, there has been no standardization.
Okay.
So the first thing is whoever is imaging a fetus should be well qualified. Whatever qualification should be aptly qualified. That is the first thing. Second is continuing medical education for the aptly
Very
qualified
important.
is a must. Wherever, whatever level we are, it is important to keep on learning and
Learning.
reading. This is the second important point. Now, once we come to a point where, yes, this person is qualified, yes, this person is continually reading, how can he reduce the detection? This is done by following guidelines. Presently, we have ISWA guidelines for imaging of the fetus, and we have Indian guidelines also for imaging. So, what I would like to share here is guidelines actually are devised for a basic type of imaging.
Correct.
So,
But for
by following,
particular patient, it has to be tailor made
yeah,
for that particular person.
by
Yes.
following guidelines, even today a lot of anomalies can be missed. So,
Yes.
guideline only tells that basic minimum imaging is what is this much. So that has to be followed. So let's say we
Yes.
follow the guidelines. Once we follow the guidelines, imaging is to be protocolized. That means you cannot do whatever you want. You need to have a protocol. For example, let's start with the 13 weeks scan. A lot of
Okay.
people call this 13-week scan as an NT scan. I would strongly advise to rename the NT scan as a first trimester anomaly scan,
Yes.
because
Yes.
at the 13 weeks itself, a lot of structural abnormalities can be detected. So we have to devise as to what all can be done at 13 weeks. For example, a lot of people measure the CRL and leave it at that. But the guidelines say, apart from CRL, you need to do the BPD HC ACFL as a standard. So you have 5 types of measurements of the fetus, and you can
Okay.
try to see whether there is a discrepancy between the body parts. Next is the aneuploidy markers. A minimum of 5 aneuploidy markers, which is the NT, the NB, the IT, the tricuspid valve, the ductus venosus, are a minimum 5 aneuploidy markers, which is a must to be demonstrated in every fetus. Once
Yes.
you have done the aneuploidy markers, then comes the structural assessment. Here we have to start with the CNS, and we have to look at the ventricles, the posterior fossa, then come to the face, look at the morphology of the face, the orbits, come to the chest, make sure that the cardia is left sided. A minimum of 2 inlets and 2 outlets in the prescribed color format has to be done. Come to the abdomen, make sure the situs is normal. Go down, demonstrate the urinary bladder, show that there are 2 umbilical arteries. Show every segment of all the 4 limbs and document them. Go back to the spine, make sure that there is no spinal dysraphism. Look at the placenta, do the cervical length assessment by a TVS, and then look at uterine Dopplers to look for PIH assessment. So this is how a guideline tells you what to do at the 13 weeks. Similarly, at 18 weeks, 20 weeks, when you do a TIFA scan, there are more stringent guidelines. When you do a fetal echo, there is a stringent guideline. For a growth scan, again, a lot of people think that growth scan is meant to be looked at only growth. No. Third trimester itself has a lot of anomalies which evolve, which are not detected in the second trimester. So, by following strict guidelines and protocolizing your imaging, the person who does the scanning can make sure that the detection of fetal anomalies can be as high as possible.
Okay. So, what are the therapeutic options that are available now, sir? Now, you told about the detection. What about the management?
Yeah. Can
How do
we
you
go to
manage? Yeah.
yeah, can you upload my
Please
slides
show
now?
the slides, sir. Please. Please show the slides of Dr. Pradeep Srinivasan, please.
Go forward.
Yeah, next slide.
Should I move or they will move? Okay,
You
I can
can,
move. Yeah, yeah, I
yeah,
can move.
please, yeah, yeah,
So
please, sir.
we go from the first slide to therapeutic options. So I will skip this. Okay, once. So the question is, what are the therapeutic options available for anomalous fetuses? So let's say that we have got an anomalous fetus. Then comes the topic of fetal surgery, which itself is in a lot of infancy as far as India is considered.
Concern.
So, fetal surgery is indicated in conditions which interfere with the normal development of the fetus, understanding that it can be corrected. So,
Okay.
contraindications. So, conditions incompatible with life, then we should not do heroic things. And when
No.
the invasive testing has shown that there are chromosome or genetic abnormalities, again, we should not proceed with fetal therapeutic conditions. So the types of fetal surgery are, the first one is called FIGS. FIGS is fetal image guided surgery. So obviously
Okay.
you are using an imaging which is ultrasound most of the times and you're performing a small surgery. Next it's FETENDO. FETENDO is again fetal endoscopic surgery which we will look at as we go forward. Then we have exit procedures. Exit is ex utero intrapartum treatment procedure. And the last is open surgery. So, in
Okay.
terms of complication, I mean, in terms of complexity, fix is the simplest, fetendo is more complex, exit is very, very demanding, and open surgery is almost extremely difficult in our
And the
types of
mortality will be very high.
very,
Okay.
very high. So quickly going into fix. Fix is nothing but a fetal image guiding surgery. So you have your ultrasound, then you are imaging an abnormality. Then you have a lot of armamentarium in your hand, which can be inserted into the, like a fetoscope can be inserted into the uterus, into the abdominal organs, etc. The simplest example for a fetus image guided surgery would be for a obstruction, bladder outlet obstruction. Let's say that there is a complete lower bladder outlet obstruction, like a severe PUV or like an urethral atresia, presenting with a full blown dilated bladder and gross hydronephrouretrosis. Now, let's
Yes.
say it's mid-trimester and you're not able to deliver the baby. You would like to get a few more weeks of time. At the same time, you know that progressive obstruction is going to cause the hydronephrosis to be so severe that there's going to be renal
Yes.
compromise. This is a classical scenario when there is bilateral obstruction involving bladder outlet. Then one can use a fetoscope or you can use ultrasound, insert just a trocar and cannula right through the fetal anterior abdominal wall in the suprapubic region. Because the bladder would be grossly distant, it's going to be very, very easy. Now the trocar goes inside and then we can deploy a DJ stent or a double J stent inside. One part of the stent will be in the bladder, the other part of the stent would be in the amniotic fluid. And then you can remove off your trocar and then the stent stays there. What it does is the urine now has an outlet directly through the stent into the amniotic fluid. The pressure in the bladder reduces, the pressure on the kidneys reduces, and this
Yes.
can give us time and then it can protect the kidneys from severe damage. So this is the simplest type of fix, which is insertion of a double J stent into the bladder. So other examples or fix are when you have anomalous twins, you can do radio frequency ablation of an anomalous twins, especially in a monochoric setup where you cannot do a KCL injection into the anomalous twin. You can use this fix to ablate the anomalous twins cord and then try to demise it. Then similarly, when there is a large pleural effusion and when there are large pericardial effusions, we can insert shunts into the pleural space or pericardial space. A very, very unique thing which has been done even in our country is balloon dilatation of aortic
Yes. Yes.
stenosis.
That's what it
Yeah.
is being done by the interventionists.
Very,
Yes,
yeah.
sir.
So basically, when there is a severe aortic stenosis, which is so critical, and when rest of the morphology of the heart is normal, you know that if you go through the left ventricle from the chest wall, if you go through the left ventricular apex, enter the aorta, and then do a small balloon dilatation,
Followed.
most of the times the
Even for
aortic.
the pulmonary stenosis also we do
Yes,
it. Yeah.
yes, we can definitely. So this is another example of FIGS. And thoracentesis is something. This is something which I have done. You can see the needle here inside the thoracic cavity. That was a chylothorax which we relieved in a 30-weeker, and
Okay.
subsequently the fetus progressed very well, and it was delivered without compromise of the lungs.
Very
So
nice.
this is again thoracentesis, which was something which we had practically done. That was how the fluid looked like. This
Chylothorax. Okay.
this is a pre-procedure, and that's post-procedure. There's a good enlargement of
Excellent.
the lung. Yeah. Now,
Lungs.
fit
Yeah.
endo. Fit endo is something which is more complex, cannot be done by routine fetal medicine people. It requires training in fetoscope. So basically, it is after under anesthesia, there is a fetoscope which is introduced into the oral cavity of the fetus. Now, this can be done for congenital diaphragmatic hernia. We all know that if the diaphragmatic hernia keeps on increasing, the lung becomes very small and then choked, and then postnatally it's a problem. So, what can be done through the fetoscope? We can enter the trachea, and then we can release balloons in the trachea. By occluding the trachea, what happens? The ipsilateral lung, which is compressed by the diaphragmatic hernia, does not have an egress. So the secretions of the lung stays in the ipsilateral lung, and the lung is more turgid and does not allow the diaphragmatic hernia to compress it. Thereby, the ipsilateral compressed lung has a ability to retain its morphology and size. That is one example. Twin transfusion, laser coagulation of vessels can be done. Acardiac twin cord ligation can be done. Amniotic bands, we can do resection of the bands. So these all can be done using a feet endo or endoscopy. So that is
Excellent.
congenital diaphragmatic hernia. So with a balloon occlusion, we can achieve that. This is laser coagulation in TTS. Now, coming to open surgery, these are very, very rare, and then it is done in Philadelphia in the US, where we have a few people who do great work in this field. So, basically, the mother is anesthetized, the uterus is opened like a C section. The amniotic fluid leakage is prevented by surgical staples. Under sonological guidance, the fetal part is identified, the fetus part is exteriorized, and the surgery is done. A good example for this type of surgeries are large CPAMs when lobectomy can be done, sacrococcygeal teratomas where the teratoma resection can be done, meningomyelocele where the repairs can be done. The fetus is then interiorized, and then the uterus is closed, and it's allowed to continue its life. So these are examples of fetal surgical procedures. Now, exit procedure is something which is done right at the time of delivery. Now, basically, exit is ex utero, intrapartum, where the cord is still attached and the baby is still alive. So, it is an intervention that occurs during delivery with only the head out of the uterus. The airway intervention requirement in the fetus is done. It usually provides baby good airway by bronchoscopy or tracheostomy before pulling out the fetus. So this is a procedure which is called exit. And examples of exit is when there is a congenital high airway obstruction. You know that as soon as the baby comes out, it's going to get
Yes.
choked. So we can just exteriorize the baby and then do a bronchoscopy or a tracheostomy, and then cut the cord and remove the baby out. Also, it can be done when you have instilled a balloon in congenital diaphragmatic hernia. Once the baby's head is exteriorized, you can do a bronchoscopy, remove the balloon, and then do the C-section, and then cut the cord and remove the baby. Similarly, in pulmonary sequestration, CCAM, etc., the airways can be taken care of as at the time when the baby is still getting blood from the mother, and it's an excellent way of preserving airway and then taking out the baby and protecting it. Recent techniques are gene therapy, which means replacement of a missing gene by introducing a foreign nucleotide sequence. So it can be a stem cell therapy or a gene therapy. And these are very exciting newer types of therapies which can alter
For the future.
fetal, yes, which can alter the
Yeah.
fetal
Yes.
makeup.
Yes.
So with this, I end
So
therapy.
thank you very much. That was an excellent presentation of what is present and the future. And one
Yes.
last question I would like to ask as a radiologist, if
Yes.
one particular intervention you would like to say, which will have a greatest impact, what is it?
Actually, more than the therapeutic intervention, I would say one great intervention is the diagnostic intervention, which we do, like an amniocentesis, has a
Yes,
great role to play when there
yes,
is a structural anomaly or a marker which is present to decide whether to continue or not. So, I would say, as an intervention, if you
excellent.
consider it as a diagnostic or therapeutic, a diagnostic intervention has a great role to play in today's era to
Yes,
decide whether a fetus should continue or not, because most structural anomalies can be corrected, but the chromosomal and genetic abnormalities cannot be corrected.
excellent, sir.
Amniocentesis with
I
NIPT
perfectly
would
agree
advocate,
with
no,
you.
sir?
Next slide, please. Yeah, go ahead, Parimala.
I just wanted to ask, sir, amniocentesis with NIPT, like, are the two something like which will really
Yes,
make
ma'am.
us more
Actually,
strong coming
yes,
to the
Next,
diagnosis?
next question.
yes, ma'am.
Yeah, go ahead. Go ahead, sir.
Okay. So since the topic of NIPT has been raised, I would say that I have a lot of reservations with NIPT. NIPT has a 98% reliability for trisomy 21. The moment we move outside trisomy 21 to 18, 13, and other abnormalities, the sensitivity of NIPT falls to as low as 60%. And we move out to single gene abnormalities, it is very, very poor. So NIPT has to be reserved only when the suspicion is trisomy 21, and only when we have certain markers which are of not much importance, like an echogenic intracardiac focus, like pelvic ectasia, or a double marker abnormality or a quadruple marker abnormality, which could be wrong or false positive, or when there has been a prior history of a Down syndrome or family history of Down syndrome. So these are certain indications where the risk is not very high. I would say an IPT can be used. The
Yeah.
moment we have multiple markers, or we have a structural abnormality in the fetus, or we have a prior strong genetic or chromosomal abnormality which has a propensity to repeat, NIPT is not the way to go. Amniocentesis or CVS is the way to go.
Thank you. Thank you very much, sir. Can we move on to the next speaker question? Yeah. So thank you very much, Dr. Pradeep. So we move on to the next question to Dr. Srinivasan. Next slide. Dr.
Yes.
Srinivasan, which congenital heart defects are most commonly preventable or modifiable among the maternal risk factors?
Thank you, madam. We have talked about this already during this session. One very important aspect of maternal well-being is maternal nutrition. All of us have heard about Ford or Baker hypothesis. That is the
Yes,
fetal onset of adult disease because of
yes,
poor maternal nutrition. So it is very important for a pregnant mother, even before conception, to have a well-balanced nutrition. So for calorie protein supplementation definitely has shown reduced incidence of congenital heart disease.
correct.
Micronutrient deficiency like vitamin D, B12, folate, vitamin A, zinc, copper, selenium. So these do not have very strong evidence, but yes, so it has to be given as a
Yes,
general
suspect.
supplementation.
Yes,
Yeah. Maternal infection prevention is of very important reason,
very
like
important.
vaccination against chickenpox, rubella is very, very important. Control of maternal illness like SLE, diabetes mellitus, phenylketonuria, obesity, hyperthyroidism, all of them decrease the incidence of congenital heart disease by 1.6 times. So avoiding teratogens has been already told, like alcohol, smoking, recreational drugs is very important. And certain therapeutic drugs like antiepileptics, NSAIDs, heavy metals, all of them needs to be avoided. There are certain modifiable factors when it comes to maternal ailments. Folic acid supplementation in therapeutic doses, not very high doses, in
Yes,
therapeutic doses are known to reduce neural crest defects like tetralogy and all other conotruncal anomalies.
yes,
If a mother has SLE or Sjogren's syndrome, so there is very high incidence that the fetuses might be born with complete congenital heart block. This can be monitored and prevented by timely initiation of steroids. Certain arrhythmias, if they are detected on time, can be treated transplacentally by giving medications to mother. So, as it has been already mentioned, critical lesions like aortic stenosis, pulmonary stenosis can be intervened in specific indications to prevent a fetal demise or progression of a uh, aortic stenosis patient into HLHS. So these
Yes.
would be certain modifiable risk factors as far as the maternal indications are concerned.
Now, once you detect the congenital heart disease, then how it changes the outcome later on? And
Yeah.
at what time do you do the fetal echo, and what are the anomalies that you look for, and how do you advise the parents?
Yeah, now the field of fetal echocardiography is actually progressing leaps and bounds. I would say the ideal time to do a fetal echocardiogram is any time after 12 weeks onwards. So between 12 to 16 weeks, it is called as the early trimester scan, where we can detect most major congenital heart defects like single ventricle physiologies, heterotaxis, and things like that. So, but if you want to detect all the congenital heart defects, so I would recommend a scan between 16 to 18 weeks. So, none of the fetal echocardiography should be delayed beyond 18 weeks where the mother is at risk. So, once we do an echocardiography at 18 weeks, so there are several category of patients whom we see. One is a baby who has a critical congenital heart disease.
Yes.
So during the counseling, if we diagnose a very bad heart disease like hypoplastic left heart syndrome, where there are very limited therapeutic options, especially in a poor patient, so family still has an option to undergo termination of pregnancy. So huge number of correctable heart lesions like a straightforward VSD or a tetralogy of Fallot, if we diagnose them at 18 weeks of pregnancy, so we would advise them an amniocentesis and a complete genetic test. So once we rule out that the baby has a significant genetic abnormality, so we can say that we can continue the pregnancy. However, this baby may require an open heart surgery after birth. The
Okay.
third group of patients are very, very important where a very, very minor insignificant anomaly is diagnosed. For example, an LSVC, or an echogenic focus. If something like that is diagnosed, then we can advise the family that it's a very minor anomaly and baby will have a complete normal life as an adult. So this is the importance of an echocardiography. Very high use when you diagnose a critical congenital heart disease, and extremely very important role when you diagnose an insignificant congenital heart disease. It will reassure the parents that they can continue the pregnancy and have
Yeah.
a normal living baby.
Yeah, that's really nicely, very beautifully you have explained. And in fact, there are many centers where they are not doing the fetal echo and they land in trouble. For once, what happened was there was a hydros fetalis. They did the cesarean section in the evening, and the baby did not cry. They put the baby on the ventilator, and then the baby was shifted to our center. And they know that hydros fetalis was because of pinpoint aortic stenosis. So I did the balloon dilatation with just 14-hour baby, and then the baby recovered completely. Within 24 hours, it was weaned out of the ventilator. So probably nowadays in Hyderabad and other centers, they are doing intrauterine balloon dilatation, whereas here, it was done afterwards. So here, if we detect in time, we can literally save the patient and the life of the child. And that is the example. So shall we move on to the next question to
Yes,
Priya?
ma'am.
Yeah. Thank you very much, Srinivas. It was
Thank you, ma'am.
very nice to explain so beautifully. And now we move on to Dr. Shiv Shankar. Dr. Shiv Shankar, welcome. And he's a neurosurgeon. What role does the preconception folic acid and supplementation help, especially in the for the neural problems?
Uh, as we all know that prevention is better than cure.
Yes.
So by the time most of the female come to know that they are pregnant, already the baby has a neurotic defect. So supplementation with folic acid has a significant role to play in prevention of these neurotic defects. Almost on the statistics, 70 to 80% of the time, supplementation with folic acid can prevent this defects formations. So actually, it has to started as Paribala ma'am already told that a year before, and especially in India, probably across world, pre-conceptional counseling is quite poor, and even most of the couples they don't reach, and they are not aware of the scenario, and most of the pregnancies they happen without taking in folic acid. And once it has happened, it is quite difficult to treat. So prevention is better than cure, and folic acid supplementation has definitely helped the couples.
Now,
So
why are they coming late despite giving, advising and everything and detecting in time? Why do they reach late to the doctor?
uh, mostly it is because of the Pradeep sir was very much right that ultrasound is done by different specialties and people of different efficiencies in detecting these defects. So it is mainly a technical challenge, and it depends on the efficiency of a person who is doing it. At the same time, in peripheries, the technical challenges are the penetration, even the quality of the ultrasound machines what they have has a great limitation, and even the people doesn't have much of education to reach to the bigger cities and get it done. So that's how most of the neurological defects they come to us after delivery. So either they are missed or they are conveyed, but they're not understood, and they continue the pregnancy. So Parimala ma'am might be seeing it day in and out, and she might be advising. Sitting in Bangalore, it is quite easy for her to advise for the educated patients. But in the periphery, most of the patients are uneducated, and it's quite difficult to convey them and make them realize that what implications the child might be having. So that is
Yeah.
one thing, and there are some lesions like occult lesions, the closed lesions, which are difficult to detect in the prenatal period. And some markers might help, as Dr. Pradeep sir was telling, mainly amniocentesis, AFP, and acetylcholinesterase. They might help, and sometimes they may not. If the neural tube defect is not open, even they are not much raised. So that's one issue. And it is very much right that timing of scan. So as we discussed, by the 28 days, the neural tube closes, and after that, the defect is evident.
So,
Actually, to
what
add
about,
up some,
yeah,
sorry,
please.
madam, some neurological defects are some syndromes, some anomalies are detected very late. I think Pradeep sir will be able to this one. The
Yeah.
recently case
Yes,
what we
yes,
had,
yes.
We,
So
yeah,
assist
we,
the 7 month muscular dystrophy or some exactly that syndrome what we
yeah.
diagnosed this. Sir.
Actually,
We
the third
help us.
trimester, third trimester anomaly itself is a nice big chapter for us. A very
Yes.
classical condition is achondroplasia, where until the 20-24 weeks, you have the limbs looking absolutely normal. By 28 weeks, you start looking at significant rhizomelic shortening, and that is when you really realize that achondroplasia is evolving. So this is one
Yes.
condition which gives us a rude shock in the third trimester. Similarly,
Yes.
development of gonadal cyst comes later. Small diaphragmatic hernias can come later. Small bowel atresia is usually happens in the third trimester. So there are a lot of conditions which come up in
And
the third
muscular
trimester.
dystrophy, no, sir. That muscle
Yes,
development problem
yeah,
also. What
yeah,
we had recently.
yes.
Yes.
Those sometimes may not be diagnosable antenatally at all.
Yes.
Okay, okay. That means early ultrasound and early fetal echo, and then regularly repeating it. And
Yes,
even the third trimester repeating is very, very
very
important,
important. Yes,
even if it is normal in the first trimester.
yes.
So, what protocol do you advise to reduce this neurological morbidity, sir?
Actually, the
Especially in the spina bifida.
if we detect isolated spina bifida, if I detect in a fetus, I'm usually not very worried at all, ma'am, because it's a
Okay.
closed neural tube defect, and it may involve one or two levels, and we give a good prognosis, and we do not trouble them that much. What the in the first trimester, the intracranial translucency, which is a great marker for ONTD, should not be missed, because sometimes the spine may be difficult to image, and once there is a ONTD, the intracranial translucency, which is the fourth ventricle, gets obliterated, and that's really a part of a normal image of our NT-NB when we take. So like that, there are a lot of markers which tell us about open neural tube defects in the first trimester itself.
What about the hydrocephalus?
And that is a very overt diagnosis which should not be
it's quite
missed by
evident.
any at all. It's a very obvious diagnosis. When once the hydrocephalic comes, then we are trying to see whether it's a ventriculomegaly alone, or it's an aqueduct stenosis and a X-linked recessive hydrocephalus, or are we dealing with a holoprosency spectrum of hydrocephalus? So a dilated ventricle itself has its three great ramifications to be looked into. That's an overt diagnosis. Our worry is missing out on subtle findings, which a great learning has to happen.
Okay. Thank you very much, Dr. Shiv Shankar. Shall we move on to the next panelist? That was a nice explanation. Next slide, please. Yeah, now we move on to Dr. Priya. Welcome, Dr. Priya.
Right.
Then, how exactly should explain the carrier screening become routine for all the couples? Please explain about the risk and the based on this.
Right. So, carrier screening, when we speak about it in the technical sense, is something called expanded carrier screening. Now, this is not done for everybody. There is something before that we need to come across. So, I've been hearing all the panelists speak, and I completely agree with them that the first meeting with the patient, a good history taking, understanding
Very
what is
important.
family background, putting a three generational pedigree chart, looking at what is running within the family is very critical before we jump to any kind of screening. Now, for example, I've seen somebody like we had spoke about muscular dystrophy, very
Yes.
difficult to detect in scan, absolutely impossible. In fact, most muscular dystrophies, especially the common ones, DMD, develop only after 6 years of life. So the
Okay.
child will be born absolutely normal, but they have
Yeah.
a very short lifespan. By 10, 15 years, they don't survive at all. So understanding the history, there is a mother whose brother had muscular dystrophy. So we can
Yes.
screen this mother who's now a high risk to getting a child with muscular dystrophy is something very critical for which a good family history and pedigree matters a lot. Secondly, like sir was saying, they come to us very late. You can imagine at what time they come to a
Yes.
geneticist. By
I
the
know.
time they
I
come
know.
to a
I know.
geneticist,
I know.
everything is almost over and the window span is very less. So I prefer that everybody incorporates whenever they take the history and they find these red flags, they should be referred to a geneticist who can
Okay.
decide on the appropriate test. So I have seen somebody for muscular dystrophy doing a karyotype or a whole exome sequencing. We will get no answer. It will be negative and will be falsely reassuring that the right test would be an MLPA to do to detect the diagnosis. So understanding what is at risk and ordering the right test is the first and foremost step. Coming to what is this carrier screening, especially in South India, we have a lot of consanguinity, which is
Yes.
common among us. So they're married within the families. Now,
Family.
yeah, just if I can have my slides, is that possible? So when we marry within the families, we are prone to something, while the slide loads up, we are prone to something called autosomal recessive disorders. All
Yes.
of us, if you do a genetic testing in me, you do genetic testing in Pradeep sir or anybody else, all of us are carriers for some abnormalities. Carrier means out of the two copies of genes that we have from the father and the mother, one copy is abnormal. So it doesn't harm us because the other copy is good, so we can still continue to have that protein. But if two people with similar abnormalities in single copy when they marry, and both the abnormal copy comes to the child, then the child can have a serious disease. So for this, for all consanguineous couple, according to ACMG guidelines, we've also given a carrier screening guidelines. I don't know why the slide is not loading up. We have
Yeah. Can you show the Dr. Priya slides, please? Ankane, please show the slides. The next time onwards, you give it to me,
It's okay. I mean, if it doesn't load up, it's okay.
No,
It's
no.
that
Can you show the slides?
I'd uploaded.
Yeah.
Yes,
Yeah.
that's true.
Good.
Can we go
Yeah, move
further?
the slides. Yeah.
Can we go down the slides? So this generally carrier screening is done for autosomal recessive and X-linked disease. Just come to the next slide, please. So this is how it'll be. A carrier father and a carrier mother will have an affected child in only about 25% of the cases. In 75%, they will still have a normal child. To understand which child or not, we give something called as carrier screening, which has three components. We have whole exome sequencing, we do something called SMN1 MLPA, and we also do CH panel plus or minus based on what is available for them, alpha thalassemia carrier testing, and Fragile X and DMD testing. Next slide, please. Next slide, please. So, according to ACMG guidelines, every person needs to do a thalassemia and SMA screening in India. So, these are
Yes,
universal
yes.
recommendation. Apart from that, those who are married within consanguinity, they are come under Tier 3 classification of ACMG. So, they should be offered an expanded carrier screening. Next slide, please. So this is the carrier screening guidelines which we have helped to formulate by the Indian Academy of Medical Genetics. So where we should offer the carrier screening, whether there is a significant family history where we're trying to trace out the gene of interest for us, where there is bad obstetric history, multiple fetal death, 2, 3 with similar abnormalities, they have passed away. We have to look for it, and the baby's test, of course, is not available, and consanguinity. This should be offered in the pre-test counseling only, because by the time the report comes, a lot of USs will be there. By the time we resolve that and then give a prenatal testing by amniocentesis, we're already far down the lane here. So carrier screening should be offered by a clinical geneticist, and carrier screening should be done only after taking a detailed history, because there are multiple nuances in this which needs to be well understood before offering. I
Yeah,
can
next
take the
slide.
next question.
Yeah.
Okay, so the next question I think which was given to me was about what is the relevance of genetic testing in various branches. So since this is a reproductive medicine panel, preventive birth defects panel, I'll in reproductive medicine for offering NIPT, invasive test, in recurrent pregnancy losses, bad obstetric history, planning a pregnancy, infertility, optimizing ART. So we do throw around words called PGTs, PGA, PGM, PGSR. What are all this? How can we really accomplish it? What is the difference between PGTA versus PGTM? And what are complications to do a monogenic testing with a PGTM? All these are very important nuances that we need to understand and then offer. And coming to the next slide, genetic medicine has now kind of occupied the entire genetic services. So, right from prenatal, infertility, pediatric cases to childhood neurological cases. So, now we know cancer is a genetic disease, it's a molecular disease. So, what we do mostly in our hospital also, based on which gene is affected, for instance, BRCA, we decide which chemotherapy can be given. So for BRCA, we give olaparib. For MSH mutations, we give checkpoint inhibitors. So it's become so specific on treatment based on the genetic diagnosis that it has taken all the fields of study. Next slide, please. So for aneuploidy screening guidelines, there was a question where what is the benefit of NIPT versus the carrier screening ultrasound? So NIPT can never replace ultrasound, and I agree with Pradeep sir that NIPT has significance only as a screen, and it is good for only trisomy 21. So we have to use it sparingly, and when you get serious anomalies, NIPT is not the test of choice. The test of choice will be determined by what type of anomaly. For example, if you have a skeletal dysplasia, if you do a chromosomal microarray, you will never get an answer. You will always get it in a single gene disorder. So, understanding which test to order for what is very, very important.
Correct.
Coming to
Absolutely.
next slide. Okay, I think how ultrasound and genetics have merged, that's what we have tried to look at here.
Okay.
So, as ultrasound has increased in its sensitivity, geneticists also have started to evolve with it. So now we have a great collaboration between fetal medicine experts and geneticists,
Yes,
especially when the reports become very complicated, when you get VUSs, how to interpret, what to do, what is the prognostication of the child. Even if I do all these fetendo and other surgeries, is this an isolated abnormality, or will the child end up having intellectual disability or other complication, where such
yeah,
surgeries, even after doing a successful surgery, we might not really improve the quality of life for that child.
yes,
So these
yes.
become very important to understand before going for all
So,
of that.
so thank you very much, Dr. Priya. What is the biggest challenge for you to counsel the parents, and what advice do you give to the clinicians so that they don't miss referring the patients to you in time?
So because genetics
Gets
is a
lot
new
of references, madam. Very much wanted geneticist is.
No, the moment Dr. Priya talks to us, we realize that okay, we need to send the next patient also there.
Yes, yes. One patient of me, what Pradeep sir diagnosed that muscular this one. Then they came by going through Priya. They said after Priya madam has told myself and you are out of the scene. After Priya madam has told we want to go for consultation.
no, no,
There are a
nothing
lot
like
of
that.
appreciation. Thank you,
Thank you
Priya.
so much for that,
Appreciate it.
for the trust you have in me. But quite often, to tell you very frankly, genetics is a newer branch. We can't give you 100% answers all the time. And there are too many things that we are still trying to decipher and understand. We're trying to build on it. We are trying to see how to resolve these VUSs more better by doing functional studies and others. But in a prenatal setup, as Pradeep sir said, only 10 to 20% of structural abnormalities can be found. Now, things like intellectual disability, whether the child will have seizures post birth, all these we can never know with scans. And genetics sometimes can be so clear cut. You get a pathogenic variant, you have an answer. But sometimes it has its nuances, which can be very difficult. Coming back to your question, ma'am, what's the takeaway for what should be done? So a good pedigree or a good history at every level. This is the basic that we learned as MBBS students. So every level, the history is the most important thing.
Very
And
important. Yes,
when you feel that there is something where there is a significant family history, there's consanguinity, there's bad obstetric history, a right workup and the right genetic test would really change their entire scenario towards the end. This is something that I would highly advocate. And of course, when you come with scans and scan based abnormality, a genetic testing would really help to uh, give the right prognostication for that child,
correct.
so that we can decide
Absolutely.
how the child will be in the future, and then decide how to carry today's pregnancy forward. That's the
So,
basis.
thank you very much, Dr. Priya. Now we move on to the last person, though the time is, we have come to the end of the time, but the
Very
final
important person,
words
madam.
from them, yeah,
USA.
but the final one is by Dr. Mamata. You please go ahead. What is happening in the gene therapy? Please tell us.
Okay, first of all, thank you. And it's my privilege to be here, join the other experts to throw some lights on genomics and gene therapy, right? So there is a new
Do you have the
technique.
slides or?
Um,
Okay,
I do have few slides, but
okay.
given the
Yeah,
time constraint, maybe
no,
I
no,
will
it's
just
okay. Go ahead. Yeah,
okay. Um, I just wanted to bring the context for genomic medicine, gene therapy. You know, there is a field now, they have nailed down the terminology. Now it's going to be called as precision medicine. There were terms being floated like personalized medicine, individualized medicine, and then they settled on precision medicine. Under this umbrella, there are a lot of pillars, and one of the pillar is the genomic medicine. The genomic medicine is more advanced today than any of the other pillars because the technology is there to measure or to sequence the DNA. Whereas the technology is not as far advanced in other fields. You know, we know that protein is very finicky. To do a high throughput protein test is very difficult. Though the work on the protein has been going on much longer than on DNA, but DNA, because of its long shelf life, and also um, the advent of the photolithography that's used in semiconductor industry, which allowed for the high throughput measurement of DNA. The first technology to come out is the microarrays, right? That was an overlap between semiconductor industry and the biology that led to this revolutionary technology, where before late 1990s we could only measure one gene at a time, but now we can look at the whole genome at once with just one single test. So, given that we have understood a lot of nuances, as Priya explained, because we are able to get that, screenshot of what's going on at a given point of time of the whole genome in a cell. So now, having understood this, we know that many of the birth defects are also rare diseases, where it's not motivating for the pharma companies to develop the drugs because there is not a huge market for it. In such cases, gene therapy and comes into picture, right? And now, because of another new technology called as CRISPR, um, technology, which allows the modification of the gene in the body, it is possible to have a gene therapy. So, to explain in layman terms, CRISPR is like, you take a scissors and cut the bad part out and insert the good part in where it's been manipulated in the laboratory. I think Dr. Pradeep showed a slide where he said we use a vector to insert this modified DNA sequence into the body. So there have been a lot of setbacks in gene therapy because it's not as easy. As we know, though we evolved from a single cell, but we have very different phenotypes in our body, right? We have eyes, nose, but it's hard to imagine that they've all come from a single cell. That's because of gene expression, that's DNA expressing as RNA, which will execute the different phenotypes or the morphologies in our body. So understanding how to express this inserted DNA in different parts of the body is quite challenging. But recently we have seen that CPS1 deficiency, I think Dr. Vijayalakshmi passed the video to the group, where we can see that they have been able to successfully target the expression of this gene only in the liver or only in the somatic cells and not
Okay.
affecting the reproductive cells, which might impact the future generation of that patient.
Okay.
Uh, Sorry, did you have a question?
No, no. Go ahead.
Yeah. So, so the gene therapy is really, really at its very infancy stage. It's almost like preconception stage, almost, or the day one of the pregnancy. So, in future, you will see a lot of these therapies coming into play. Um, Especially the single gene disorders can be modified, and as Priya explained, some of the complex traits, uh, the gene therapy is not amenable to such traits. But for single gene disorders, it's very possible because the single gene disorders can lead to a defective enzyme or a protein, right? And by just replacing the bad part or a single variant with the good one, can um, correct the deficiency.
Yeah. So thank you
Any
very much. Do you have anything else, or we can take any questions if they are there from the audience?
I would like to
Any,
add one thing.
yeah, please, please, please go ahead. Yeah.
So this NIPT testing with the sequencing, that is the whole exome sequencing and whole genome sequencing, is becoming stronger and stronger and more practical because of the cost factor also being reduced. For example, the microarrays, I worked for Affymetrix, the company that developed the first microarrays. The cost of a single chip microarray or a single microarray that costs around $100 today used to cost $50,000 in
Okay.
1998.
Okay.
So the prices come down tremendously, and the same will be the case for the next generation sequencing. And right now, the NIPT testing done with the screening may not catch all of them, but the accuracy will improve because we are doing a very low depth sequencing right now. It doesn't even cover the genome completely once. So, as we increase the depth of the sequencing, as the cost goes down, we'll be able to catch more anomalies in the chromosomes. So that is the hopeful fact of it. And one thing that I would like to add to the Indian condition is that, it's not about doing more genomic tests or sequencing tests, but it's more about doing it smartly, as Priya explained, after studying the family history, selecting the right panel, doing it smartly is the right way to go about it.
Okay. Thank you very much, Dr. Mamta. The one question to Dr. Pradeep, what is the role of AI in the fetal anomalies diagnosis, sir?
Yeah. So as we speak, AI has already come into our equipment. We just bought a new machine called the Z20 with AI. So basically, what it does is, now let's say I do the head, I sweep the head from vertex to neck. Presently, the type of practice is that you have to freeze at the transthalamic plane, the transventricular plane, the transcerebellar plane, and then you'll have to do all these planes one by one and then do your measurements. So now what is happening is you just take one sweep from the vertex to the neck and just de-freeze it. Then what happens? The AI immediately analyzes the entire volume. So the machine is now doing volume analysis. So as soon as you
Okay.
take a sweep of the head, it does all the planes by itself, not only in axial, but in coronal and
Okay.
sagittal, measures
Oh,
6 to 8 measurements, what you do over a period of 5 minutes, labels it and gives it to you. So
wow.
this is where we are today
Amazing.
practically. Even the,
Amazing.
even fetal echo, if you have an apical view, zoomed apical view properly, you take a sweep from the base to apex of the, you take a sweep from the upper to lower end of the heart. Then you will have a 3D volume set. Then it
Okay.
guides you to place certain pointers, like one in the interventricular septum, one in the IVC, one in the apex of the heart, like that. Some 5, 6 seeds, if you place, like how it tells you, in just 1 or 2 seconds, you will have 9 images of the fetal heart with proper
Wow.
labeling: axial,
Wow.
sagittal, RVOT, LVOT, short axis, 4 chamber, 3 vessel tracheal, in just 1 second.
Excellent.
So this is where
Excellent.
we are.
Mamata, you have to add anything? Yeah.
Yes, I like to add something because I come from the informatics side. Um, to enable AI, which is very limited today, as Dr. Pradeep already mentioned in his first part of his talk, uh, standardization is extremely important. The more and more we standardize, the more AI tools can be uh, developed, or the algorithms can be developed. So the more we standardize now and collect the data in a uniform way, this will allow the AI algorithms to be have a very good training set, for
We
AI to come.
Yeah, we already are supplying images to various AI people. So they have told us how to capture images and give them in multiples to them. And using them, they are able to create the AIs.
Yes, I think the radiology is one field where it is more advanced,
Yeah.
but in other
Yes.
fields, it still has to catch up.
Yeah.
It has
Now
to
they have
catch up.
moved. Now these companies have moved from normal to abnormal. So recently, I have a request for congenital heart diseases during my fetal echo. They have requested me to give for TGA, TOF, and certain other DORVs, etc. Once we diagnose them, they have requested us to give in a particular zoom, in a particular view, the 4 chamber, the 3 vessel, the inlet, the outlet, etc., on the anomalous hearts. So now they are gathering information from anomalous hearts to create AIs for certain subsets of anomalies.
Excellent, excellent, sir. I think the AI and the technologies advancement have almost They are going at a rapid speed. But what is lacking is bringing awareness among the public. What is available, what is there. So only the few people are reaching in time to get the benefit of these advances. So I think we have to reduce that gap, and so that even the common man, they can see that the anomalies can be prevented, and getting an abnormal child can be avoided. That should be our goal. And let us all work together as a team. And then I thank Dr. Parimala Devi, Dr. Pradeep, Dr. Srinivas, Dr. Shiv Shankar, Dr. Priya, and Mamata. All of you have explained excellently, and it was very candid and a very beautiful presentation by all of you. And thank you very much. And Shubharatri to all. Thank you.
Thank you very much.
Bye.
Thank you.
Thank
Thank
you.
you very much.